Hi, this is Elliot Fishman, and welcome to part two of two on mucinous cystic neoplasm. I discussed a lot of the facts about cystic pancreatic lesions in the prior talk, focusing on MCNs, and showed you some examples. I want to show you some more examples, try to show you a spectrum between low grade and intermediate and high grade, and what things I'm looking for. Vague abdominal pain. 2.5 centimeter lesion, could be an IPMN, but I would see a pancreatic duct typically. Great location for an MCN, particularly if it's a 40-year-old female. Well defined, you can see the wall. There's no enhancement. This was an MCN with low-grade dysplasia. There was no nodularity, there was no mural nodules, there were no septations. Another one a little bit larger, same location. You can see atrophy of the distal gland. There's a faint calcification medially, which is not uncommon, but it's not dystrophic calcification. You can see it again through a range of views, and that was also low grade. Another one, a small lesion, body of pancreas. Great location, no duct communication. This one, it almost looks like there's some vague rim enhancement around the lesion. I showed you almost a similar case before. When I start seeing what looks like enhancement, I also will consider a neuroendocrine tumor, and I'm really thinking about that. Neuroendocrines often do not dilate the duct, but they can have calcifications more frequently than MCNs. But this was tissue sampled and eventually resected. And this was an MCN as well with low-grade dysplasia. When you have a lesion like this, however, just to compare, this is large, right? You're talking about over 10 centimeters. Thickened septations, but look at the nodularity. When I see nodularity, a lesion like this, I could say serous cystadenoma, but you don't get those nodules around the edge. The location is perfect for an MCN. There's atrophy of the gland. The patient's in their 40s. This is going to be a high-grade dysplasia. As I mentioned, we have pathology to help us. But when you have nodules like this, when the septations are thickened, and of course the size of the lesion, that alone would make you highly suspicious for malignancy. But again, beautiful example of the stroma, the nodularity, and high-grade dysplasia. Nothing very tricky in this case. Another example, when the lesions get large like this, they're not always high-grade dysplasia, but typically that's what I assume they're going to be. And particularly here, you have so many septations. There's wall thickening, there's some nodularity. Again, you could think about, you can imagine a serous cystadenoma, but those are typically cysts and occasionally septations. This more is pushing me to MCN, and I would worry also here because of size and the extent of septations about a high-grade dysplasia, and in fact, this patient had an invasive carcinoma. You would have liked to detect this a little bit earlier, and often patients will have these lesions and they don't present. If they're asymptomatic, you could actually lose that perfect window before it becomes high-grade dysplasia or before it becomes malignant. Another example, this is like 6-7 centimeters, perfect location, minimal duct dilatation. Really good example. There's some soft tissue. I would worry at least intermediate grade. This is going to be coming out regardless. But thickened septation, soft tissue nodules, this is a very concerning lesion to me. Here's a few more looks at it. This was low-grade dysplasia. So again, I don't think we're going to be perfect on that, but I think this lesion needs to come out. Based on size, the septations, the patient was very lucky. But distal pancreatectomy, the patient should do well, good long-term survival, and you basically have cured this patient. Another example here, the body lesion, same size as the prior case, but again, calcification, but no septations, no nodularity. Think about the last case, think about this case. Here it's sharp margins. I'm much more comfortable that's low-grade dysplasia, but it ended up being an intermediate-grade dysplasia. So again, I think this is the reason why I never see the day where people are going to rely on us to simply look at the images, unless we have AI, which gets really good, because there's such overlap. Now again, there's overlap because pathologists call things differently, but you can see the challenge it is. Intermediate grade, it's wonderful to do a distal pancreatectomy. You've cured the patient before they developed cancer. And here's just another one. Here the lesion is cystic. The borders aren't sharp. There's some septations. This ends up being low grade, but again, the septations, it's not that large. And again, under 4 cm, it's less likely to be malignant. But again, look at the soft tissue density. I worry. When I see those soft tissue density, I worry at a minimum of an intermediate grade. But this will get a distal pancreatectomy. The septations are also seen on the cinematic rendering. Maybe a little bit better on the cinematic, but that was resected. And again, another one very similar to a couple of cases ago, septations, cystic components. Again, think about the cases together. But this is going to be resected. It's over 4 cm. And as I mentioned, most people will remove anything above 2. And the question is, should you remove below 2? But you're going to take it out as a way of preventing cancer. And this other lesion here, again, this is not as sharply marginated. It has thickened septations. It looks like wall thickening as well. This lesion really concerns me. MCN is a good differential. Could this be a cystic or necrotic adenocarcinoma? I couldn't exclude that. I would worry about that. There's atrophy of the distal gland and slight prominence of duct dilatation. So if you said this was a cystic pancreatic adenocarcinoma, I would not argue with you. But this is a concerning lesion to me. This will need to be resected. And this was resected. Intermediate grade dysplasia. Okay, good. Another one, 41-year-old, low-grade dysplasia, well-defined. Another one, thin septations, a larger lesion. Calcification inferiorly. Again, you would worry, but this was low-grade. Again, it's large. It's about 6 cm. You can see on the volume rendering on your right the patient's septations. Again, differential diagnosis could be anything else. I guess I could throw in a serous adenoma, but the age will help me. You can do tissue sampling if you need to prove it, or you can just do a distal pancreatectomy, which this patient did have. So again, these cases are indeed very challenging. Septations are often better seen on venous phase. So I do look more carefully on the venous phase for the septations, but the mural nodules, particularly the enhancing component, may be seen a bit better on arterial, sometimes venous. But again, I think you're going to see them well. And we mentioned about doing cinematic rendering as a way of accentuating mural nodules and accentuating the presence of septations. And here's just a few additional images showing you very nicely the septations. Another patient. Now this lesion is larger. It's irregular borders. There's thickened septations. This one, high-grade dysplasia. Not much of a trick. Here it is again. Large lesion, cystic, slightly thickened wall, no mural nodules, but septations. Again, you're beginning to see, hopefully, and I showed you a lot of cases on purpose. I got all my cases together to make the point that we're very good at suggesting the diagnosis of MCN if we follow all the rules, but I don't spend a lot of time trying to determine the degree of dysplasia unless I see like a mural nodule and enhancement. Then I'm saying I'm concerned for high-grade dysplasia or for carcinoma. But trying to say low-grade versus intermediate, the lesion's going to come out and the pathologist will tell us the answer. And here's just a few more images very nicely showing you all of those septations. And you can see why in this case you should be concerned about at least an intermediate grade dysplasia. Again, I showed you some large tumors before. When they get this large, but especially look at about 4 o'clock, there are mural nodules in addition to the septations. This is a high-grade dysplasia. There's nothing all that tricky about that. And another one, septations, a very large lesion. When the lesions get this large, obviously they're going to be resected, but the chance of malignancy, either high-grade dysplasia or outward cancer, is going to be higher. You can see the soft tissue density. You can see the septations in this large lesion. You can see some rim calcifications around the edge of the lesion. You can see, again, you're beginning to come into what looks like some nodularity here, in addition to septations. And again, I would worry about this as being high-grade dysplasia or malignancy, right? I don't think it's all that tricky. There's not much of a differential diagnosis in this case. That was high-grade dysplasia, very nicely shown. Another lesion, calcification, we said are more common when the MCN is malignant, but you can see peripheral calcification in lesions that are not going to be malignant either, so that's not too bad a problem. So I've now gone through a lot of cases of MCN. We talked about the appearance and location, body of pancreas, female, age 40, rim-like calcification at times, no dilated pancreatic duct. You can see distal glandular atrophy. You look for nodules and septations and enhancing walls, all of which become features suggesting high-grade dysplasia or malignancy. MCNs are premalignant lesions. Essentially, all recommendations to date are any size to remove them to prevent development of cancer. So I think it's important for us to be able to recognize them and help determine and accurately define what they are. We are doing work, other people are doing work, trying to use AI for determining serous versus mucinous versus pseudocyst versus SPEN, trying to use LLM data as well as CT data and lab values and put everything else together. So I think in a couple years, you're going to have some help from AI. And with that, that's the end of part 2, and I hope you enjoyed the talk. Have a great day. If you like this video, make sure to subscribe to the CTisus YouTube channel. You can also visit us at ctisus.com for even more videos, plus quizzes, pearls, protocols, and oh so much more. We're also in the App Store and have well over a dozen apps for iPhone and iPad, all completely free. Thanks for watching.